from the American Academy of Pediatrics.
When we treat the patients in front of us, it's impossible to know everything that's going on in their lives.
That's why it might be best to treat everyone as if they've experienced trauma.
We have to consider bullying. We have to consider discrimination, racial, ethnic, gender identity, sexual orientation. And we have to really, in the world we live in, consider natural disasters and, of course, pandemics.
Plus, new research in pediatrics focuses on counteracting internalized racism.
As people start to kind of internalize those stereotypes as true, that can be really dangerous, especially in a population with children as they're learning things that they will believe about themselves, moving forward for life.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about trauma-informed care.
You know, Joanna, it seems that your work life at CHOP and your podcast life are intersecting all the time here. But today, it's time for my very own crossover episode.
Oh, I'm so curious. CHOP, as a large academic center, is always really quick to adopt and incorporate new recommendations by the AAP. But I know in the community hospitals where you work, change can be harder.
You know, we do work hard to keep up with evidence-based medicine. My practice in Goldsboro recently became interested in screening for or somehow addressing adverse childhood events, and they were looking for advice. It just so happens that I also work at the Med-North Community Health Center in Wilmington, where our pediatric medical director is my friend, Dr. Khadijia Tribié Reid, a national expert in trauma-informed care, so naturally I turned to her.
We have heard from Dr. Tribié Reid in the past on this program's Giving Voice segment, and now we get to interview her. Dr. Tribié Reid serves as the governor's appointee on the North Carolina Partnership for Children's Board of Directors and at the AAP on the expert leadership team on building capacity for trauma-informed care. Khadijia, welcome to the show.
Thank you guys so much for having me. I am delighted to be here. As I've told you both, I am a fan.
Well, I'm a fan of yours, so it goes both ways. Can we start with a little bit of history? I remember the first time I learned about adverse childhood events, or ACEs, and I felt like we had uncovered the Rosetta Stone of biopsychosocial health. Can you remind us about ACEs?
Sure. So adverse childhood events is exactly as it sounds. It's adversities that occur during childhood. And what we found is that these adversities have an outsized impact on adult health and adult outcomes, morbidity and mortality included. Over the years, these adversities have expanded. In the original ACE study, we talked about 10 ACEs, which fell into 3 different categories: household dysfunction, so divorce or a parent being incarcerated. We talked about neglect, and we talked about abuse, which could be physical abuse or verbal abuse. But over the years, those adversities we realized are much wider than that. We have to consider bullying. We have to consider discrimination, racial, ethnic, gender identity, sexual orientation. And we have to really, in the world we live in, consider natural disasters and, of course, pandemics. So the world of childhood adversity has increased so much. There's so much to consider here.
And we know ACEs can be tied to toxic stress, but they're not the only cause. And how does toxic stress influence development in children?
Really great questions. You know, Joanna, I'd like to step back and say this is the very reason I got into this work. I am a person who tries to keep up with what's happening in pediatrics, but the truth is, as I go to work every day, we see certain trends. We all do. And I'd been working in a child advocacy center where children are cared for who had been abused. And I was repeatedly seeing children who had out-of-control behaviors, walking out of classrooms, throwing over desks, ADHD, and significant developmental delays, 4-year-olds who sounded like 2-year-olds. And I realized in that moment, I said, boy, there has to be some kind of relationship between the suspected abuse or neglect that this child is experiencing, certainly the chaos that this child is experiencing, and these outcomes, which aren't good. These are not children who are functional. And so that was my initial hint that there was something here. But increasingly, we began to understand more about the science of adversity. And I said, aha, this is, in fact, what I'm seeing. And I went on to continue to see these same trends in the community health center where I worked. So this is the link. Children experience adversity. It creates stress. It increases stress hormones in their body. Those stress hormones are chronically increased, and they change our developing brains, our developing organs, and result in significant disease and, once again, adverse health and developmental outcomes.
Now, since we first learned about ACEs, we've moved forward quite a bit. I remember adding up my own ACEs when I first heard about them and thinking I am doomed to an early death. But then we started learning that adverse events are only half the story. What do we know about positive childhood experiences?
Thank you so much, David, for elevating that point. This is the big bind. So about a year ago, you guys interviewed Dr. Andrew Garner, who had written a very exciting paper called Preventing Toxic Stress. And I was like, whoa, this is the paper I've been waiting for, right? Super excited about this work. And what it elevated is the importance of relationships, those stable, safe, nurturing relationships, SSNRs. That is that one person or those two people or those few people in a child's life who are consistently present. Even despite the adversity that the child experiences, these are individuals who are consistently there. So what we realized is that children actually can become much more resilient when they have a safe, stable, and nurturing relationship. And that is what we really want to foster. And in fact, that's what pediatricians do every day.
And putting this all together as pediatricians, let's talk about the concept of trauma-informed care. What does it mean to practice trauma-informed care?
Yeah, I think the work of trauma-informed care really operationalizes this work of ACEs. So many of us were kind of at a loss. What do we do with this information? Abuse, neglect, all of these things. What are we supposed to do in our office practices? In summary, I feel like trauma-informed care truly helps us realize, look, we can't just go into the office and look at the skin and diagnose the rash and diagnose the delay. We have to consider the environment outside of our office spaces. We have to consider the homes in which people live, the communities in which they live, and natural disasters. Whatever else may be impacting their lives is also impacting their health. And it's really important for pediatricians because, after all, we are here to optimize outcomes. That's why we talk about vaccines. That's why we talk about anticipatory guidance. So why on earth would we ever leave out the impact of trauma on outcomes?
So when you're in the office and you want to practice trauma-informed care, what does that actually look like? What are you asking and how are you approaching the family?
Thank you for asking that, Joanna. I think there's no better way to answer that question to give you a story to exemplify. There's so many elements of trauma-informed care, and many of them, they can't be placed into an algorithm so easily, but they're elements that are certainly there. So I had a young mom come into my office just yesterday. She looked tired. So I acknowledged that. I said, girl, you look tired. She was huddling her little 4-month-old beautifully. She was doing just the type of cuddling we like to see. And she said, I just got out of work. I said, well, boy, it's 8:40 in the morning. You just got out of work. You work overnight. She said, yeah, I do. 5 days a week. I work overnight. And I amplified that. You made it to this appointment and you worked all night long. Wow. Now, who's going to take care of the baby when you get home? And she said, I'm going to take care of the baby. Light bulb. Gosh, how are you going to take care of this baby? And you've been working all night. So first point of acknowledgement there. And then as she's talking, she says, me and dad and baby's dad have been having a little bit of an issue. And in my mind, this is a young mom. So I think, okay, teeny bopper argument stuff. They're trying to work through their relationship. So I continue to examine baby. And as I'm examining baby, stethoscope in my ear, she continues to talk. And I realize she's saying something about the situation with dad. I said, wait, let me take off my stethoscope. I want to hear what you're saying. I lean in to what she's saying. Ultimately, what she's describing is domestic violence. She's saying to me that there was a domestic violence episode. She did call the police and she pressed charges on her baby's father, which was very challenging for her. Here she is, this young mom working 2 jobs, has her second baby with baby's dad, is doing all the things. He's been a loving dad. I've seen him. I know him personally. He's a loving dad. But we know that domestic violence is an adversity. And so in some way, we have to talk in that visit about how we really don't want to expose our babies to adversity. I want to affirm you. You did what you had to do. We have therapy here. May I offer that to you? Maybe I can bring a social worker into the office right now to see if there are any resources that we can offer. And I will add that this is a mom with whom I've been working for about 1.5 years. I've taken care of both of her children. The relationship is there. She felt like she was in a safe place. Maybe you would go to another place and say, well, they'll call DSS on me if they found there was domestic violence in my home. But I know that she's a loving mom who's really trying to figure it out and do the right thing. So that's one element of trauma-informed care. And I would almost say it's the most amplified form because, of course, we have integrated behavioral health. We have social workers on site. We have therapists on site. So that's one way it's done. It does not have to be done to that extent. We have to find ways that are feasible for our various settings to do this work and truly lean in when families are giving us information that truly is important for their child's health.
Just last week, we aired an episode about intimate partner violence, and I know we're all inspired to try and provide the kind of care you just described. At the same time, pediatrics is a seasonal business. We're going into school physical season, and a lot of our colleagues are going to feel really rushed, like they have to get all these kids through. How are they going to see everybody? And they may be worried that this kind of care is going to take more time than they have. I know that you're doing this routinely and not running behind because I've seen it. What kind of tools can we use just to help us get started and yet also see the patients we need to see?
I think that is really important, David. We're busy. We have a lot of patients to see. So we really do have to customize our infrastructures around how we will address this work. It certainly could look different in different practices. Certainly, there are universal screenings that most of us are doing. Those could be the ASQ or the ASQ socio-emotional. Over the past few years, I learned to use the SWIC, which is the Survey of Wellness for Young Children. It includes 2 or 3 social determinants of health questions on there. And so these are some of the tools that we may be using. Adolescent screenings often ask about adversity. So these are some of the things we may be using in our office practices already they're allowing this work. Once again, some of this is just the subtle work of leaning into little comments families make right there in our office. And then ultimately, I think that each office has to figure out what relationship will they have with community affiliates or community resources that may be doing a lot of this work with them. Whether you embed a social worker once a week in your office, or perhaps you just have a really good relationship with your neighborhood WIC. These are the type of tools we want to be able to provide warm handoffs to our parents. So we're not just putting another thing on their to-do list, but in fact, helping them move through this work.
And what if you have a family that, though, feels offended that maybe you're asking them some questions they find personal and they don't see as related to their child's health? I mean, these can be really sensitive asks. How do you engage those families and keep them coming to your practice?
I think that is something that many pediatricians worry about. I've actually had pediatricians name that as a concern. Listen, Number one, we are doing a lot of this work already. We have relationships with these families. I'm watching kids graduate from high school who, when I started my practice, they were my babies. So when you have those long-standing relationships, you really do have a lot of leeway with families. Often what I'm doing is not necessarily asking, are you abusing your child? But I am, in fact, leaning into cues. I had a mom come in today and say she wasn't feeling well, or actually I noticed that she was on crutches. And when I realized she was on crutches, well, it opened up. I created a space, right? My room is space. My office is a space where you are free to say, and I'm not working right now, by the way. And my child is acting up in school and acting in ways that I know we have ADHD, but he's leaving the classroom. Well, guess what? If we're trauma informed, it widens our differential. We don't just say ADHD. We say, gosh, are there any new things happening in your home that may have caused this? And then we find, wow, you and your partner broke up 6 months ago. Wow, you're not working. Just FYI, mom. These little things can absolutely disrupt a child's regulation and executive function. And so these are the type of things we really want to pay attention to. But thankfully, I always see you, mom, at these appointments. You're here. You're consistent. You are his safe, stable, nurturing relationship. And as long as he has that, you guys can get through these hard moments together. So I think it's just part of the work we're doing. We're widening our differential. We're levying the relationships we already have with the families that we're serving. The work is there. It's integral to our practices already.
Khadijia, do you think there's a stigma around ACEs and trauma-informed care? Like maybe there's potential to blame or shame the families we treat?
Yeah, I do. I think, unfortunately, the work of trauma-informed care has been placed in a bubble, like it's for those people over there, maybe those who are poor, maybe those who are underprivileged. But I think we have to rethink that notion. When we talk about neglect, we really need to think about postpartum depression. How many women are impacted with that and really can't create that secure attachment with their babies? In the face of pandemics, like COVID-19 or natural disasters, there is no discrimination there. That doesn't depend on poverty. And often, things like COVID-19 bring on secondary disasters like job loss and death and mourning and depression, as we all saw in our practices with our adolescents. So it's really important that we all lean in to this work. And it's not just for any particular person. It's all for the health of all children.
Khadijia, I'm going to be lucky enough to see you soon, but for our listeners who won't, can you leave us with one takeaway from our conversation today?
I want us to really think about not only the parents as safe, stable, nurturing relationships, but us as safe, stable, nurturing relationships. In that vein, I'll leave you with another story. I have a family that I've cared for many years. They used to come in with their mom. Their mom didn't ever look like a particularly happy camper, but we had a guy at the front desk who does billing, actually. He always had these Happy Meal toys, and he would always be sure to give her kids the Happy Meal toys. Well, one day, the children came in without mom. Mom had suddenly passed. Turns out what we didn't know is that she had ongoing chronic medical conditions. So they were then turned over to another caretaker. When I continued to take care of those children, and that caretaker, after some years, became unavailable to take care of these children. These children, several of them, went into foster care, different foster care homes. Well, they came to me with their foster parents. And I would look at one of those children and say, "Little Johnny, how you doing today? What's going on?" And the foster mom would look at me and say, "You know him already?" And I said, "Of course. Been taking care of him for 10 years. We are that safe, stable, nurturing relationship often as primary care pediatricians and primary care providers. So this is the work that we're already doing. So I ask us to wrap our policies, our follow-up plans, and our relationships with communities and our advocacy around this very important work that will impact the families that we serve and their health.
Wow, you've opened up so much space for pediatricians to really embrace trauma-informed care. So, Dr. Khadijia Tribié Reid, thank you so much for being here today.
Thank you, guys.
To learn more about trauma-informed care, visit us at aap.org/podcast.
Coming up, we'll look at internalized racism and what it means for minoritized populations.
I remember walking down the street with my daughter in Philadelphia when she was 4 years old, and there was a Black Lives Matter protest ahead of us. And in the typical, honest, and observant words of a 4-year-old, she asked me, "Why are those Black people so loud? Are they angry?" What would you have answered to that, David?
Oh, Joanna, give me a second here because there is so much to unpack in what you said. Your daughter saw a group of people protesting, not knowing what a protest was, and she saw they were of a different race than her, and she was trying to process all that in real time. I mean, what did you say?
I tried to help her understand every person has different experiences growing up, and that sometimes those experiences can be based on how you look, like what the color of your skin is. And I think a lot about it because she was nodding as I was talking, and I sort of wonder if I did a good job helping her understand race and its place in society. But it was a learning moment, an opportunity for the both of us, really.
I am sure. It is wonderful that you're thinking about this with her because you need to be ready to talk and teach about race and identity in a moment's notice when you see it, whether you're a parent getting asked questions by your kid or a pediatrician listening to your patients. I know a doctor who can help, Dr. Antwon Chavis.
Dr. Chavis is the first author on a new paper in pediatrics, Internalized Racism and Racial Self-Identity Formation in Black Children. He is also an assistant professor of pediatrics and general pediatrician at Oregon Health and Sciences University, Dornbecker Children's Hospital in Portland. Dr. Chavis, welcome to the show.
Thank you so much.
So, Dr. Chavis, there are different forms of racism, but your paper focuses on one in particular, internalized racism. How do we define that?
So I would define internalized racism as it's different from more or less systemic examples of racism or the interpersonal kind of personally mediated racism forms as a means of taking the information and stereotypes that exist about a certain racial group and members of that group kind of internalizing those things and kind of leading towards almost like acceptance of them as true, which can then shape the way that they interact with the world and those around them under the perception that all of those stereotypes that are expected of them are accurate. And as people start to kind of internalize those stereotypes as true, that can be really dangerous, especially in a population with children as they're learning things that they will believe about themselves, moving forward for life. It can allow for them to internalize a lot of really dangerous stereotypes that don't have to be true, but oftentimes kind of become true unless there's active pursuit against it.
It's common to say that children aren't born with racism, but must be taught it. Is that true? How does race become internalized?
Sure. I don't know that a child's understanding of race is truly taught just because there's so much kind of instinctual things that happen just along the course of development that are almost kind of milestones, things that I would expect a child to learn and understand without, really being like provided that perspective. So things like even just a simple like racial identity, being able to determine that I am the same race as someone else, or those two people are the same race. That's something that starts even in infancy, a time that oftentimes parents are probably not even thinking about how they're teaching their children about race. And a lot of the internalization happens as one experiences a lot of either racial incidences or taught things just through kind of intergenerational experience transfer. And it's a lifelong process for many, but I think the purpose of a lot of what I wrote about is how we can help children as they're going through that process navigate it in a safe and controlled way, being aware of the milestones that they'll develop, whether we intend for them to or not.
And you wrote about the racial identity formation in Black children in the United States. Can you give us a little bit of the history there?
Yeah, I mean, just in terms of being Black in America, there's been a lot of changes in society's acceptance of Black people really doing anything. And so as we began even just becoming accepted in like the basic school systems, there's been work in determining how Black students, accepted themselves and understood themselves to be smart and talented and able to, contribute even within the school system. And there are the past studies, the research studies, like, the doll study that I talk about in the paper, where children get to look at a doll that looks Black and a doll that looks white and determine which one has essentially more value, the way that the study is truly like boiled down to. And as they develop this negative perception on, the Black dolls and how smart they are, how capable they are, or, how worthy they are of being played with, that really personifies like the bigger narrative that Black children kind of experience. And so it was really important to me as a Black pediatrician with a large Black panel. I wanted to make sure that I was advocating for that group because I was once a part of that group, and I've had to go through the process of creating my own racial identity, often without the support of my pediatrician, but it would have helped out a lot.
You mentioned that children as young as infants begin to show distinction and preferences, and Joanna was saying that her 4-year-old was clearly able to distinguish race. How does racial perception develop during infancy and early childhood, and how does that shape kids' sense of their own racial identity?
Sure. At first, it's very much unbiased. It's just being aware of different facial features of different racial groups. And so starting as early as like 3 months, children can say if they've got a racially congruent caregiver. So if it's a Black child being raised by a Black mother, they can look at photos of healthy Black women and they'll spend more time examining the Black woman compared to a photo of like a white woman or an Asian woman, not out of bias against the other two races, but out of recognition of a similarity of the Black woman in the photo and their own parent. And that can extend even as early as 6 months to using same race individuals for infants to determine, like to take cues from same race individuals. So a research study where children are shown video of a same race individual and a different race person, and they have a visual cue where they look at a certain aspect on the screen, and then something happens on that side of the screen. And so whenever there's two people with competing visual cues, children will then look at the person who looks like them that has the same race to take cue. So if the Black person looks to the right and sees something, the Black child will say, oh, well, I'm going to see something if I look to the right, as opposed to whatever the other race individuals were doing. So, and again, these aren't as biases against the other groups as much as almost like evolutionarily built things that help to keep a child safe and to know what happens next.
And you mentioned it would have been helpful talking about this with your pediatrician. What are ways in which pediatricians can help children promote a positive racial self-identity?
Yeah, that's a great question. Honestly, I think the first step is just talking about it. In my office, if I see a white child, sometimes that child will say, you've got brown skin. And the parents are like, oh my God, I'm so sorry. Like, I don't know how I was like, no, like I do have brown skin. Like, she's not wrong. So, and then it opens up this bigger conversation of, what else do I have that might be different than you? And they'll say, oh, like you're a boy and I'm a girl. Or you're tall and I'm small and I'm an adult. And, things that are all true things that don't diminish my value, that just make me different than them. And so I actually love having that conversation at work and like in the community, because it happens kind of all the time. But I think for one, just like leaning into it, I think is just important. And sometimes acknowledging the elephant in the room. Like if there's a very clear cultural difference between you as a provider and the patient that you're trying to like build rapport with and provide care, honestly, I think the first step is just even acknowledging that to some degree. If they are a religion, if it's Ash Wednesday and they've got an obvious clear like delineation of that, you can acknowledge that and say like, oh, I see you had a religious celebration today. If they are in a very specific, a child that has cultural makeup on or something that you aren't familiar with, or a garment or a necklace or something that's very clearly intentional for cultural reasons, honestly just saying, I've never seen that before. What is that from? Or if I speak a language you don't speak, saying, what language are you speaking? What cultures do your family celebrate? What cultures do you hope that your child one day grows up to celebrate? That's really, really helpful because it just allows for just open conversation and dialogue. And that allows for parents to feel safe, but also it models for children that like these are safe things to talk about. If they can see two adults that they trust, theoretically, having those same kind of big conversations. So I mean, I would say first and foremost, just lean into it and then kind of be aware of your own biases, of course, and then educate yourself as much as you can. And oftentimes the patients will do a great job of doing that. I learned more about Dia de los Muertos and certain Hispanic holidays or like Chinese New Year from patients that celebrate those things than I have from my own personal experiences, because people, they expect me to teach them things, but at the same time, they love to educate their pediatricians on things that are important to them. And so kind of humanizing yourself and allowing that to happen can break down a barrier that can really improve the way that we provide care for these kids. Did that answer your question?
Yeah, and I was curious too, do you ever spend time trying to explain the benefits of racial equity and helping to promote allyship, especially if you have children from a more dominant racial subgroup in your community?
Yeah, I oftentimes will acknowledge things like, if I've got a Caucasian child that's well-adjusted, gets good grades, very social, obviously very likable, very charming in the office, we see those kids all the time, and the parents are like, oh yeah, like they just have tons of friends. I say, that's great. So hopefully you do a good job out of helping kids that might have a hard time or that don't have many friends, like feel safe at school. Do you know any kids like that? And they're like, oh yeah, like so-and-so, I had them sit with me at lunch the other day because they were sitting by themselves. I'm like, that's great. Sometimes people look at kids like you and they think that you're smart and you're funny and that you're talented and you can do all of these things. But some kids go to school and they don't have those same perceptions, and that can make them feel pretty unsafe or feel really sad at school. So hopefully you can find some time, since you are, well-liked, and you've got all of this, support through school, to help support some other kid that might not look like you that could use a friend at school as well. And I'm not saying that you are better or worse or the same. I'm just saying that all kids deserve to go to school, have a friend, and feel safe.
Where can pediatricians go for resources when they want to be intentional about addressing internalized racism and helping empower their families who may have been marginalized or devalued?
So there are a lot of resources that exist, mostly through certain websites or certain YouTube videos, a few books that I've liked that are really helpful. I think healthychildren.org is obviously a good place to start, just in terms of like AAP appropriate resources on talking to children about things like race and racial bias. There is embracerace.org, which is a really large, kind of expansive set of resources available to parents that talk about like a lot of things. So how to have a child that's like a transracially adopted child, things to take into consideration for that, or how to build a diverse playroom, how to choose a book library that has characters that are of a different race, but that are still like useful and provide a good education for kiddos. There is a YouTube video called Something Happened in Our Town that I really liked. It's kind of like a read aloud of a book that helps to put some scarier things like protests and like police brutality episodes into like child-friendly language. And it's important just to be age appropriate too. I think for younger kind of toddlers, I think it's mostly a matter of exploring the types of differences and letting them see that, that skin can look different and that different isn't bad. And I think for school age kids, it's more a matter of helping them to kind of process through like traumatic experience that they might have witnessed or that they have seen or heard about, and being aware of some internalization that they might already be processing, whether that is internalizing of themselves as a part of the social dominant group or processing their internalization of themselves as a marginalized kind of member of society.
This has been so helpful. Do you have any last stories or takeaways for our listeners before they go read your paper?
Yeah, I think I can think of a couple of just like personal examples of patients that I've encountered that I'm just very glad that I was there to meet with them that day. One was a 10-year-old Black girl, beautiful, intelligent, brave, smart, who was just losing a ton of weight. Labs were normal, didn't understand why. And then when I just had time to her, like alone, she acknowledged that she was starting to be bullied at her largely white, predominantly school because she was Black, and that she felt like she wasn't beautiful. And she thought that she needed to lose whatever small amount of weight that she had as a 10-year-old to feel more beautiful, which was just devastating. But it opened up so much really positive conversation that made a big difference. And something more simple, I had a 4-year-old little boy, and in all my checkups, whenever I'm looking in their eyes, regardless of the race, I ask the kiddo what their eye color is, just to see if they know. And the 4-year-old swore up and down that he had blue eyes. And the mom thought he was playing. He's like, no, like, what color are your eyes? He's like, Mom, my eyes are blue. Like all my friends' eyes are blue. And it was like the mom's first time of really like being aware that her child didn't know what it meant, like what like being Black was, or being Black was different, that they hadn't had any of those conversations, and they were doing so as a means to protect them. But that kind of left him open to creating their own perception of what their race was, based on what they observed from other people, which can be really dangerous, at times if it's done in a way that is without any like parental guidance. So I don't know, I think just having the conversation is important, learning more about our patients in terms of the languages that they speak, the cultures that they celebrate, the things that are important to them and the experiences that they have, and know that, you're not going to know all the right answers, neither are the parents, but the biggest goal is just to try. People love to have their pediatricians learn more about them and their cultures, and I think that that's an important thing that we should be doing more of, is exploring and having good discussions on the topic of race.
Well, Dr. Antwon Chavis, we have learned a lot talking to you today, and thank you so much for joining us.
Of course. Thanks for having me.
To read the paper, Internalized Racism and Racial Self-Identity Formation in Black Children, go to our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Joanna, with small children, this may be hard for you to imagine, and it was for me too, but our youngest child is starting college. We are officially empty nesters, and he is spreading his wings, and I'm pretty sure going to fly, or at least eat worms or something. I don't know.
Well, mine is about my kids too, and that's that my daughter is really into the pregnancy and the growing belly.
Ooh,
and so every morning
cool.
now she's like lifting up my shirt or my dress. That's awkward. And just giving the baby a hug and a kiss. And that's actually been one of my most favorite parts of my pregnancy so far.
Oh, that is so sweet. I love that. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call, and on Twitter at Peds on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about pediatric mental and behavioral health emergencies.
We'll speak with Dr. Lois Lee and Dr. Mo Saidinejad. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.